Thank you for the introduction. So welcome to the 10th Annual CARES Conference. My name is Daniel Lee, and I've been given the honor of being the medical director of the program today. So from the beginning, the CARES Conference was designed with you in mind. So it's designed to be a patient-centered experience, and a lot of the topics that we'll be covering today and that we've covered in the past have been inspired by our interactions with you in the clinic, have been inspired by the thoughtful questions that have been brought up by yourselves and your family members. And I hope that you walk away from this meeting with a little bit deeper knowledge and understanding of glaucoma, its treatments, and the tools that we have to help you tackle glaucoma on a day-to-day basis. So before I move on, I do want to acknowledge and thank the Glaucoma Service Foundation and the Harley Foundation for the funding and their hard work for allowing this conference to work the way it does. And I do want to acknowledge all the speakers and all the volunteers who have really donated their time to make sure everything runs smoothly today. So without further ado. So the topic for today is fluid flow inside the eye. So understanding fluid flow inside the eye helps us to understand eye pressure. Eye pressure is important to the development, progression, and treatment of glaucoma. And we know that lowering eye pressure has shown to be an effective treatment for all forms of glaucoma. So knowing the natural fluid flow inside the eye helps us to understand why pressures are elevated in glaucoma and how the treatments we give you reduce your eye pressure. So a little overview of the anatomy of the eye. So the cornea and the sclera you can think of as the outer wall of the eye. The cornea, of course, is the clear dome-shaped part in the front of the eye, and sclera is what we know as the whites of the eye. The iris is a colored part of the eye, and in the middle of the iris is an opening called a pupil. And this pupil allows for light to pass through to the back of the eye where we can process what we're seeing. Right at the angle where the iris and the cornea meet is the trabecular meshwork, and we'll go a little bit more into detail as to what this does, but just know that this is probably the primary site of fluid outflow of the eye. So it's basically the drain of the eye. Behind the iris is a ciliary body, and this is where the fluid inside your eye is formed. This structure, of course, is the lens, which is a clear structure that allows that focuses the light into the back of your eye. So the front of the eye can be divided into two compartments. There is an anterior chamber and a posterior chamber. The iris basically acts like a wall that divides the front portion of the eye into these two compartments. And the pupil is like a door or like an opening for the fluid to be able to move freely between the front and the back. So aqueous fluid is a clear fluid that fills and circulates the front portion of the eye. It has several functions. One, it helps the eye keep its shape. It provides nutrients, and it helps remove waste products. I just want to note that the cornea, which is the front portion of the eye, and the lens are completely clear structures, and they are devoid of blood vessels. Because of this, these structures rely heavily on the aqueous fluid and its flow, because the blood vessels typically serve to bring nutrients and remove the waste. So the aqueous fluid does serve a very important role in making sure that these structures work the way they do. So a quick overview of the fluid pathway here. So like I said before, the ciliary body is where the aqueous is produced. The fluid then passes through the pupil from the posterior chamber to the anterior chamber. And it will circulate around the anterior chamber for a while before it finally drains out through the trabecular meshwork. Now, the majority of the fluid does drain through the trabecular meshwork, but a small portion of that fluid also exits through an alternative pathway called the Uveoscleral Outflow pathway. We'll go into all of this in detail. So first, aqueous production. So aqueous is produced by three mechanisms. Probably the most important mechanism is the active secretion, which basically means your eye is expending energy and working really hard to pump fluid into the eye. The other two are ultrafiltration and diffusion. These do not require energy, and it's considered what we call a passive secretion method. Active secretion probably accounts for about 80% of the aqueous production, and incidentally, this form of secretion is what we typically target with our medications and some of our surgical lasers. Now let's talk about aqueous outflow. Aqueous outflow occurs through two pathways. There's the trabecular meshwork pathway, and then the second uveoscleral pathway. Just want to highlight that the trabecular meshwork pathway represents a bulk of the outflow of the eye. Once the fluid passes through the trabecular meshwork, it goes through a very complex network of pathways before it enters back into our systemic circulation. And this video over here nicely demonstrates that. So just to orient you, that circle, white circle in the bottom is the cornea. That darkened area around it is the sclera, which is the white of the eye. And a dye called fluorescein dye was injected into the anterior chamber. And you're seeing this dye kind of traverse through the trabecular meshwork and all of the pathways that follow it. This big blob of vessels here is called the intrascleral plexus. Eventually, they coalesce into what we call episcleral veins. And from the veins, it enters back into our circulatory system. Just to touch upon uveoscleral outflow, unlike the trabecular pathway that you just saw, the uveoscleral route does not have well-defined channels. So we think of this more like seepage of the fluid through the eye. So it seeps through and in between tissues, like the ciliary muscle, interstitium, suprachoroidal space, sclera, lymphatic vessels, a lot of things. It's a not well-defined pathway. So now that we have a general overview of the natural fluid pathway of the eye, how does eye pressure become created? So eye pressure is generated by the balance between the rate of aqueous production and outflow. So in other words, if the eye is making more fluid than it can get rid of it, then you would expect higher eye pressures. And if the eye is getting rid of the fluid faster than it can be made, then you would expect low eye pressures. In the case of glaucoma and people with high eye pressures, typically this occurs because there's an impaired outflow mechanism. It's rarely because the eye is making up too much fluid. So it's not increased production, but impaired fluid outflow. And in fact, we know that aqueous production goes down with age, as does aqueous outflow. But we also know that aqueous outflow rates decrease more rapidly. And for this reason, as we age, in general, the eye pressures tend to go up. So let's talk about the effect of glaucoma on the normal fluid pathway. So there are two major forms of glaucoma. One is open-angle glaucoma. The second is called closed-angle glaucoma. In open-angle glaucoma, we can see that the aqueous has a clear access to the trabecular meshwork. For one reason or another, the aqueous has a hard time passing through it, and that's the problem with open-angle glaucoma. In closed-angle glaucoma, the aqueous does not have access to the trabecular meshwork. It's usually because the iris is bowed in a certain configuration so that it blocks its pathway. So therefore, in both of these instances, outflow is decreased and eye pressure is elevated. So we think in open-angle glaucoma, the aqueous has a hard time traveling through it because there is an accelerated rate of debris accumulation at the trabecular meshwork. So this is an electron micrograph or a very magnified view of the trabecular meshwork. On the left side, this is what you'd expect in a normal eye. You see the trabecular beams there and nice little spongy holes for the fluid to pass through. And on the right side is what we would typically tend to see in somebody with glaucoma, where those little spongy holes are plugged up with what we call extracellular matrix products, and it's harder for the fluid to get through. So how do glaucoma treatments work? Generally works in a couple ways. So the first way is we try to reduce the production of the aqueous fluid, and the way we do that is with medicines and with lasers. So some of the medicines would be an alpha agonist like brimonidine, beta blockers like timolol, carbonic anhydrase inhibitors like dorzolamide. There are certain surgical lasers that we do to treat directly the ciliary body and the ciliary processes, and that kind of turns down the faucet so that the drain has time to catch up. The other way is we try to increase outflow. There are several medicines that do this. So we have the prostaglandins, like latanoprost or Travitan, and we have miotics like pilocarpine that increase the outflow. Some of the lasers we do in the office, like the laser trabeculoplasty, makes the trabecular meshwork work a little bit better so that fluid has an easier time leaving the eye. And finally, most of our incisional surgeries, the ones that require stitches and things like that, increases outflow of the fluid out of the eye, and that's how we try to achieve lower eye pressures. So all of these treatments are going to be covered at some point in this meeting in greater detail, so I will not go more in detail with that. And that will basically conclude my portion of the talk here. We're really proud of the talks that we have assembled for you today. Again, I hope you walk away from this meeting a little bit more empowered and equipped with knowledge of the treatments of glaucoma and about the disease process itself. And certainly we are open to any feedback that you may have after this meeting, and we're always looking for ways to improve. So thank you very much for your attention.
Everyone,